rearranged non-small cell lung cancer represents about 4% of non-small cell lung cancer, and it's a true driver oncogene. So this is something that goes wrong. Usually these are never smokers, and that rearrangement in the ALK gene is what's driving the cancer. And the great news that we've known for over a decade now is if you give an ALK inhibitor, you can get dramatic shrinkage of the cancer, which can last for a long period of time. The field changed over the last few years with the development of next generation ALK inhibitors that have largely displaced the first generation drug, which was crizotinib. Crizotinib's major Achilles heel was twofold. First of all, it didn't get into the brain, so a lot of patients with ALK-positive lung cancer get brain metastases, and so that was a site of progression, and many of the next generation drugs get into the brain. And then also the crizotinib allowed multiple on-target resistance mutations to emerge, so mutations in ALK that were not suppressed by crizotinib. And again, many of these next generation inhibitors have activity against some, if not all, of those resistance mutations. The ALTA-1L trial was taking one of these next generation ALK inhibitors, brigatinib, which had looked particularly promising in the post-crizotinib setting, having the longest median PFS of any of the next generation ALK inhibitors. And they said, well, what would happen if we give it in the first line setting? So ALTA-1L, you had to be ALK positive by even a local diagnostic test was allowed. You were allowed prior chemotherapy, so it was very real world, very user-friendly. And you were randomized to brigatinib or crizotinib, with the primary endpoint being independent radiology review assessed progression-free survival. And then the other aspect of the study is that if you were on the crizotinib arm, at progression confirmed by the IRC, you could cross over to brigatinib. So it was a very attractive trial from a how to care for your patients perspective. Brigatinib from the ALTA-1L study recently achieved FDA approval because it was clearly superior to the crizotinib. The hazard ratio was 0.49. The median progression-free survival was over 2 years. And there was no difference in overall survival, but don't forget crossover is included. And that's probably a good sign because you can see that overall survival is actually the same in both the experimental and the control arm because you're salvaging these patients. A pretty well tolerated drug and clearly superior to crizotinib, met its primary endpoint and was therefore approved.